Dear listeners, welcome to Faces of Digital Health, a podcast about digital health and how healthcare systems adopt technology. I'm your host, Tjasa Zajc, and today I'm taking you to New Zealand. When this discussion was recorded on 20th November, New Zealand, which has 4.9 million people, only had 50 reported cases of COVID in the whole country. The reason the country is successful in containing the virus better than most countries in the world is the discipline of people, says Scott Arrol, the former CEO of NZ Healthcare IT, an organization connecting insurers, healthcare providers, and the healthcare industry. Scott is soon leaving the organization after running it for over 6 years. In the discussion you are about to hear, he talked about the character of New Zealanders, the complexity of the healthcare system, the hurdles related to digitalization of healthcare, and also explained how New Zealand approached the COVID-19 pandemic. So today, unlike most of the rest of the world, people can meet and attend live events in person. Enjoy the show, and to read the recap of the discussion or browse through other episodes as well, go to www.facesofdigitalhealth.com. Among the discussions about healthcare systems, you can listen to a recently published talk with Dr. Louise Schaper about healthcare and digitalization in Australia. Before that, you can find discussions about Spain and France, episodes 97 to 100 focused on South America, and there have been series about Asia and Africa published last year. Enjoy the show, and to be notified about upcoming episodes automatically, subscribe and the episodes will be automatically added to your podcast library. Now, to New Zealand. Scott, let's start with where you are at the moment. You left the New Zealand Health IT after 6.5 years. What's your reflection on digital health development and the development of NZ Health IT in the last decade?
It's come a long way, actually. It's been really enjoyable to be part of it and also to witness, so much that's been happening. So if we cast back, say, 10 years, I'd say we're sort of in the period of quite a bit of fragmentation. So there'd been a lot of systems developed in New Zealand, by some quite entrepreneurial software developers like Ian McRae from Orion Health and people like that. And as well, it had been systems that were purchased from offshore companies. So whilst it was okay, it was fairly fragmented across the whole country. So we've seen that has started to change. It has taken a while, but we're now starting to see more, I guess, consistency of systems and then the move towards more interoperability. For NZ itself, we've sort of progressed quite considerably. So we're an organizational membership, so we have corporate and organizational members, and so we've gone from 65 members sort of 6.5 years ago to we're sitting on about 160 now, and continue to grow. So with membership organizations, we talk about net growth, because you lose a certain number of members every year. There's a bit of attrition. So our net growth over the last 6+ years has been fantastic.
You basically almost tripled the membership since you took on the position of a leader of the organization. And 70% of the members are from health IT industry, and the rest are non-IT members such as healthcare providers and private insurance. Sounds like a perfect base for collaboration and actually driving progress. Is that the case? So how do members collaborate and work together?
A lot of it is about sort of like me, I suppose, creating that sort of glue to join them all together, stick them together at times. And the whole area of broadening out our membership. It was, and mixing it up was sort of a strategy that I put into place not long after I arrived on the scene, because my background's not in IT. I've been in healthcare delivery for a very long time in New Zealand, sort of 18 plus years, including this role. I was involved with the delivery and management, delivery of care, a lot of that in aged care and home-based care and community and primary. And what I found coming into this role is there was a disconnect between sort of the software writers, the software providers, developers, and what was actually happening at the coalface. Strategically, I set about sort of creating, broadening out the membership so that we would have healthcare providers and policymakers and funders from other parts of the sector who know how important IT is to their business and to their delivery of care. For some reason, being all members within that same ecosystem, it became simpler to be able to say, hey, I might be talking to someone who's telling me they've got a problem with something, might be somewhere in their service delivery model and how they might want to mobilize that or change it. And then knowing what my IT members are up to, I could say, oh, well, look, I think you should speak to these 1, 2, or 3 members. And that started to work really well. When members join, I spend time with them to understand what it is that makes them tick. If you're an IT provider, what is the thing, or what are the things that you do that you believe deliver value and is your value proposition, and what problems are you solving in the health system? I'm always talking to people who, for some reason, are telling me what their problems are, and not necessarily their personal problems, but their professional problems that they're wanting to solve. And it becomes quite simple, really, to start gluing people together or joining them up. The next level, they may not be members, but they're very close to the membership because in some way or another they can influence what our members do or don't do.
If we dig into that a little bit further, what kind of problems did you see that got solved, in the last 6.5 years? New Zealand has had a digital health strategy from 2017, which is kind of new. So it sounds like it's still fresh to think about how you want to digitize the healthcare on the national level.
True. There's been sort of strategies in some form or another for quite some time, even before 2017. I think 2017 sort of became a period where it was, we'd say, more formalized as the latest sort of strategy or framework. And part of the issue in the past with sort of government agencies creating a strategy as such has been all good intention, and in fact the strategies have been very good as strategies go, but from a governmental perspective, not really supported with resources or finance funding to make those strategies turn into actions. From a Ministry of Health perspective, it's been quite some time of trying to get the sector, so to speak, to fund the things that should be done or could be done nationally, because the New Zealand health system, for a small country, it's tends to be quite complex in a way. Mm-hmm. But fundamentally, we have these district health boards, and there's 20 of them across New Zealand, and there's 4 regions, so they sort of aggregate across 4 regions, and the funding goes to the DHBs, the district health boards. So each district health board, sort of creates its budget and its plan and gets signed off at what the Treasury and the Ministry of Health and the Minister of Health, and there's lots of sign-offs and all that sort of thing. And then every year we have our government does a budget announcement in May, usually in May, and that spells out the funding for the next few years generally, but particularly the next 12 months for all government agencies. So the bulk of that, I think it's about 75% of what's called Vote Health, that's the funding to public health in New Zealand, go to DHBs. Say the Ministry of Health or anybody else, any other agency wants to do something, let's say on a national basis, you've got to kind of influence and convince and get agreement from all of the DHBs or most of them that they will put in a share of their money to help pay for it. And the ministry has some money, but not enough to do these large scale projects. So you can imagine it's, fairly, there's quite a bit of influencing that's involved. And sometimes over the history of that sector, some DHBs have bought into doing something on a national level, others haven't, and some sort of sit on the fence in between. They'll wait and see if something is going to work before they'll commit to it. But ultimately, the DHBs sort of have, let's say, the power because they have most of the money. New Zealand, about 20 billion, it's probably closer now to $21 billion New Zealand dollars is spent in vote health. So, very large proportion of that is apportioned to all the DHBs, and then they determine what they spend it on.
You mentioned that there's 20 district health boards, and New Zealand has 84 public hospitals that are kind of combined into these district health boards. So I really wonder, how does healthcare differ among these district health boards? You said that if you are a provider of a solution, you have to go to each board separately. So are these boards competitive among each other? Is there a desire to be the best district health board? So how does the quality of care that's delivered differ across New Zealand? Is that a problem?
It does vary. I'd say quality of care, I think is fantastic. I think I think for the way that the system works or at times doesn't work, I believe that we actually deliver, above average care across the board. Now, in general terms, and there'll be areas, of course, where we don't, as a country, we do better in some areas and not very well in other areas. So don't let me sort of paint the picture that we're absolutely perfect, but the problems that DHBs have is really a function of size. So we'll have, there are, let's say, half a dozen, 6 DHBs that are quite large because of the area that they cover. And in Auckland, where I am, where I live, we've got what we call the 3 metro DHBs. So there's 3 large DHBs that cover the greater Auckland area, and those 3 are joined by the one called Northland or DHB, which is, we call it up north. So it's the Northern District area, and it's a smaller DHB with lots of rural. Only one large hospital in a city called Whangarei, and then a lot of rural settings, quite widespread and lower socioeconomic areas. So you sort of got these 3 large metro DHBs, and each one of them has their own specific kind of populations to serve, and then the Northland one is quite different to those other 3 metro because it's more a rural type setting, and so they form one region, or they fall into one region called the Northern region. So you get quite a lot of variability across those. We've got Waitemata DHB, which is the DHB in the area that I live, I think it's the largest, so it gets quite a lot of funding. It's and I'm just picking at numbers here. Let's say it's close to 1.4 or 1.5 billion dollars of funding for that DHB alone, but that reflects the population that it's serving. Whereas the one north of us, Northland DHB, gets substantially less funding, lower population, but in lots of cases, higher levels of what we call deprivation and low socioeconomic sort of population. So it's quite variable. And then when you've got smaller DHBs, and we sort of get areas, we have an area called Rotorua, which for a lot of tourists, when they're able to come to New Zealand again or have been in New Zealand in the past, we have this geothermal area, in that sort of Rotorua area it's called, and very popular for tourism. But from a population base, it's kind of, it's not growing, it's not really shrinking, but again, low socioeconomic in general terms. And their funding sort of makes it very hard for them to do anything that's innovative over and above just delivering whatever core services they can, the best they can. So, then we get down to South Island, we get Canterbury DHB, which is, the largest DHB in the South Island of New Zealand. They get quite a lot of funding. They've done a lot of innovation when it comes to IT. and then the South Island DHBs have sort of joined up with their region, and they've kind of got quite a high collaborative model. So they do a lot of innovation across their region, which kind of works well for them because of the let's say the population bases that each of those DHBs serve. So I'm not quite sure if I've answered your question, but it can be variable when it comes to IT. That's probably even more pronounced because DHBs that have struggled if they're a small DHB, they can't invest as much or haven't been able to invest as much into their IT systems.
Which is kind of a paradox because rural areas or remote areas are the ones that we tend to hear are the most in need for telemedicine and other digital health solutions, right?
That's right, yeah, and that's a good point because it sort of comes down to then each individual DHB doing what it can, and kind of you get a leader, say the CEO of a DHB, or you'll get a clinical lead quite often who has let's say a passion for example, virtual healthcare or telehealth. And I know in Whangarei, for example, Northland DHB area, they've done a lot in that area, and they've been able to get some funding from their pool of money to do some of their local projects, and because there's a definite need for it. Other DHBs where they possibly should be doing more of it haven't been, and it does tend to reflect across their sort of leadership group, I suppose, and also governance. So our board, the boards of our district health boards are a mixture of an elected, so we have public elections, and the board members is, I think, 2/3 of the board members are elected by the local population group that DHB serves, and then the remainder are appointed by the Minister of Health. So they're government appointees, including the chair and deputy chair are always appointed by the Minister of Health. So you can get a variability across the governance levels, which does it can filter through into the leadership and so on. And also remembering or keeping in mind, our DHBs run it largely at deficit. So whilst they get their funding, the majority of them, and in fact, I think at the moment all of them, struggle to let's say operate within the funding that they're allocated. They run into deficits. So effectively, if they were private companies, they would be in quite considerable loss positions most of the time, which does tend to drive a lot of their decision making. You can understand that, they need to deliver health services to their local people. So they're going to cut back in some other areas. And sometimes IT is not seen as a high priority.
That's quite common. If you have to choose between a new MRI machine or a new healthcare IT system, it's usually quite clear which one's gonna get chosen. What caused the deficit that you mentioned and the struggles that some district health boards are facing?
Oh, that's a very politically charged question. Frankly, it depends. It does actually depend sort of your political persuasion and your view of the health system at any given time. And my experience, I'll just pass on my personal experience based on So as I said earlier, 18 or so years in the health sector in New Zealand, and I've observed it across different governments. So we currently have what we call a Labour-led government, and they've just been elected in with quite a high majority. And we have a mixed member proportional voting system in New Zealand. So generally, and that's been in place for a long time, and that tends to force coalitions of government. A government that's a coalition over a number of parties, depending on the voting and all that sort of thing. So my comment is more, I've seen there's the trend with DHBs or in our public system for quite some time, and it's apolitical in my view, in the way that I view it, because we've had governments of different, we might have let's say a more right-leaning government or a left-leaning or in the middle. It doesn't tend to change what happens in the health system for some reason. A lot of them come in with very good intentions, and generally by the time they've served we have 3-year election periods. it's unusual for a government to only be in for one term of 3 years. So 6 or 9 years might be the period, and usually they come in with very good intentions and they leave without really what I call cracking the nut. They haven't really solved the fundamental problems. So anyway, I'm just giving you the ground there on how this is my opinion rather than a professional view. But I think largely the funding is determined firstly by what's a very complicated system. Well, it's complicated to the outsider. It's based on a sort of population health basis. So it says that if you've got your population is growing in your district health board area, and you might have a diversity of population groups. So let's say you've got so Maori, Pacific Island, Asian, Pākehā, European, and you've got quite a mix there, but you might have within that mix some areas that are what we termed low deprivation or high deprivation, which is generally linked to low socioeconomic. And so if you've got, unfortunately, if you've got growth in your area of that type of population base cohort, then your funding is sort of skewed towards them, towards more funding for them, but less funding for where people might be in a higher socioeconomic area, but you might have far greater population growth. So it's quite complex, and I don't even fully understand it. Our Treasury, Ministry of Health, and our Treasury kind of work all that out. It does tend to, my observation over the years, it does tend to penalise smaller DHBs who have larger populations of lower socioeconomic, and because there tends to be higher population growth in that category, and less of let's say higher socioeconomic, but it's not the funding they get based on that formula never really seems to let them or give them the ability to really deliver, let's say frontline services, proactive frontline services that are going to get ahead of the curve, and help people to kind of, in a way, take more responsibility for their own healthcare and their own well-being. It's a very difficult cycle to break, and it always feels as if there's just never enough funding and resources to create a circuit breaker.
You actually in May warned that there is a shortfall of at least 300 million a year to bring healthcare IT infrastructure up to a point where New Zealand can achieve full digital transformation. So I wonder, what is the digital infrastructure like at the moment? Where are the priorities?
It comes from a historical base of underinvestment. It's never really enabled the system and the people within the system to invest, in a very stable, strong health IT platform. Again, it's variable. We've got some good systems, stable systems. We've got some that are probably sort of creaking at the seams and struggling to keep up. And it's difficult because of the way these things are accounted for, but to actually quantify it exactly. But my calculation is that's whatever it is at the moment, it's about 300 to even 400 million a year, less than it should be. And that's based on also enough money, more money being spent to help catch up. So where it currently sits now is that in the last, say, 3 to 4 years, I've seen, on a positive note, I've seen an increase in the level of skill, experience, and competency of the leadership in the public health system, in the health IT area. So from a people aspect, I've seen some really good improvements. It's not yet consistent. It's up and down, but it's better than what it was. And then we are starting to see some DHBs realizing that unless they do invest in their IT infrastructure, they can't innovate. And they actually, talk about getting ahead of that curve in terms of the healthcare provision. Because of the leadership they've brought in or improved, they're getting the right messaging and the right strategic focus now, and saying, well, actually, you're not going to get ahead of sort of health issues until we can use IT in a much more innovative way. And the big struggle has been DHBs that have not had very stable and strong or suitable, just the basic IT infrastructure, wanting and trying to do innovative things with their IT, but it hasn't really been coming off. It hasn't been working because there's the baseline, their infrastructure hasn't allowed it. It's like what I call sort of, they've all wanted the bright, shiny stuff, but they sort of kind of put it on sort of, very, very faded old infrastructure, and it doesn't do what they expect it to do. That's changing, which is a really good thing. And we've got the National Health Information Platform business case that's moving. It's a bit glacial. It's a bit slow. I support it. NZ HIT and its members support it because it will start to see more investment put into IT infrastructure, and we'll start to see areas like interoperability, digital identity, a number of, well, again, those bright, shiny things that we should have now, and we've attempted but haven't worked so well. With investment in the health information platform, we'll start to make some really good progress for us. Going into lockdown back in March this year, COVID's kind of put you can understand, probably happened globally. It put quite a break on any other type of investment within government, just while we've fought the whole COVID situation,
Speaking of COVID, end of November, NZ Health IT organized the summit, and unlike in the rest of the world, this was not an online, but actually an in-person event. This was possible since on November 19th, New Zealand only had 50 active cases of COVID in the whole country, which is quite something that the rest of the world can be envious about. End of spring, the country even pronounced that the disease has been beaten, you were COVID-free. So I wonder, what role does technology play in this story? Does it play a role at all, or was it just pure discipline with lockdowns and the fact that New Zealand is an island, which does make a few things easier when it comes to transmission?
I think it was the discipline. I think New Zealand and New Zealanders are, let's say from a cultural perspective, where I think we have a high level of community kind of awareness, sort of doing the right thing for our fellow New Zealanders. I don't know whether you know or not, but we're our nickname are Kiwis, so we're after our sort of, it's one of our native birds. Ironically, it's a bird that can't fly, but and it's got a very long beak. But I'm not quite sure why we get called Kiwis, but we do. So firstly, definitely that when our government at the time, at that time when clearly things were looking very bad for the whole world, and our government said, look, we're going to have to go hard and go fast, and all of us are going to have to get in behind this. Well. And most of us did. There was obviously some, but that didn't really support it. But they were very much a very small minority. Firstly, I think because just the way that we kind of knuckled down, we hunkered down at home and went into lockdown, and none of us were that happy about it. But we knew that that's what we had to do. So that I think that forms the basis of why we are where we are now. And the other thing too to recall, keep in mind that 50 or so with COVID. In fact, at the moment, there might only be 2 or 3 that are not in managed isolation. In fact, because we have cases every day at the moment, but they are cases that are in managed isolation. So and they are people who have come into the country, flown in, the residents or New Zealand citizens, then they have to immediately go into 2-week lockdown. We've got hotels that have been converted into isolation buildings or units, and they get tested, I think, at least twice during that time. They can't leave until they've had a positive. Their final test is positive. There has been just recently some minor outbreaks and what we call community cases, and they seem to be linked to managed isolation. So they might be a worker in a isolation unit that's obviously picked it up somehow and got it. But because of our system, well, it does get found very quickly, and they kind of clamped down on it really, really fast. New Zealand's being an island nation definitely has helped because we've been able to close the border, so to speak. Certainly hasn't helped some of our industries like tourism, for example, but we've got a very strong agricultural sector. So we produce good food. So a lot of our economy at the moment in that respect is with exporting food, quite strong, except transport's an issue, I understand. But so anyway, coming back to IT, we weren't, and probably like most countries, except say the Taiwans of the world who'd experienced SARS and other outbreaks over the past 20 years, as a country and as a public health system, we weren't prepared at all, for a pandemic of this sort. IT, sort of did what it could, I suppose, and we developed it. We've now got a national COVID tracer app. So, and I think it's got something like 2.5 million downloads. Of people who've downloaded the app. We have QR codes, and every business in New Zealand now has to have a QR code, but it's voluntary whether you scan in or not. We've gone through a period where we had high upload of the app, but low usage of scanning in. Then when we get a community case, not an outbreak, we see people start to scan in more. It's kind of human behavior.
Mm-hmm.
So there's a problem there with, I think, a general degree of complacency, and then people kind of get a bit of a shock. And when a community case is announced, because it's
mm-hmm.
not often now, and then people don't want to go back into lockdown, so then they'll suddenly start scanning in again. As far as IT is concerned, there was quite a scramble to produce that COVID tracer app. It's not as, let's say, as fancy and flash as it could be, but our Ministry of Health people that have been involved in developing it, I think they did a very good job in a very short period of time in the scheme of things, with very little funding, to be frank, because there was we didn't have, things like PPE, and our public health system had to have a lot of funding, thrown at it. And IT again was kind of a bit of an add-on, well, what can we do to try to trace people? And New Zealand's a sort of egalitarian society, so, we can't force people to use it. You can't force them to download it.
If you have 2.5 million of people that downloaded it, that's like half of the population of your country. That's a lot, because many countries in Europe, we're at 20-30% of people who downloaded the app.
Yeah, I suppose it is. I hadn't looked at it or thought of it like that. And I think it's quite a high percentage of, when you take into account people with smartphones, because obviously children and people like that won't have a phone, so they won't have downloaded it. Yeah, so the percentage of download is very good when you put it like that. What we have found, though, that people were getting very complacent and not scanning into the premises, because I'm in the health system and I know my friends and my networks in the health system, we religiously scan in. But at the same time, I've been in, say, going into a supermarket or a store, and I've been scanning in, and people have been walking past me not scanning in. When you look at them, it just looks like doesn't even occur to them. I don't think they've really understood the need for it. But there has been talk that our government would mandate scanning in, but that could cause a few issues too, because the premises you're going into may then have to have security guards that tell people that they won't be able to enter unless they've scanned in. But we've done really well. Because we're such a small country, what we call at the bottom of the world, we take a lot of pride in kind of what we say about punching above our weight. We're very proud about doing better than lots of other countries in the world, and I think in a way this was one of those. We do very well in lots of sport, like our rugby and sailing and things like that, and we've had lots of academic successes across the world. So we do tend to sort of we take a lot of pride, and I think that played a factor too. We just wanted to show the world that we could beat this thing.
Did you see any conspiracy theories? Because basically everywhere, I think, there are groups that don't support wearing masks, that are groups that believe that COVID-19 is a conspiracy from I don't know who, and things. So a lot of negative attitude towards taking this crisis seriously.
Oh, I think there has been that, and still is. That's I'd say that's human nature. We've sort of got a saying in New Zealand, and it's not. I'm not saying that it's not a swear word or anything, but we talk about don't be a dickhead. So we kind of, if someone's being stupid, and New Zealanders in general tend to be fairly, I guess, pragmatic about things, and I'm not saying everybody, but if someone's kind of being just silly or stupid, it's okay in a way. You got to pick your moment, but it depends on who it is. But if someone said to me, if I've been saying something silly and someone says to me, "Look, Scott, stop being a dickhead," well, then you sort of pulls you up and you sort of go, "Oh, okay, yeah, maybe I am. I'll just shut up," So we do tend to be quite straightforward about these sort of things, and I guess our system, we've got a very strong democratic system in New Zealand, which does, we have freedom of thought and freedom of speech, as long as in terms of speech it's respectful. This whole conspiracy theories side of things, I don't think we have a lot of patience for it, but it's still there. And I might be showing my age as well, because I was brought up in a time when, as a young fella, if you were playing up and being silly, you were generally told to settle down and stop being stupid. So so it's just sort of our kind of the way our society is. The conspiracy theories are worrying, and particularly with around mask use and so forth, where very early on, a big part of the problem was we didn't have enough PPE, and you could understand that the government was very concerned about making sure that health workers, particularly at the coalface, had all the PPE that they could get, whilst so there wasn't a big focus on everyone needing to wear masks. Whereas in, say, like Taiwan and countries like that, with that level of experience that they've had, but also massive storage and warehouses full of PPE, it's very different to us. So it's only in recent times that sort of the adoption of wearing masks on public transport and on airplane flights has become mandatory, and people are wearing masks in other areas voluntarily, and that's good to see. What I've found personally, because I haven't been used to wearing a mask, I find it quite difficult, but you do it when you have to do it. One of the areas I find myself, and I notice other people doing, is kind of being a bit more aware of our distancing. You referred to our summit. I had 120 people for a whole day. Kind of the rule is, and we stress this with any event like that, where if you're not, you may have registered. In that case, it was a free event, so you could attend without paying anything. But even if you had paid, and if you weren't well and couldn't attend, we would encourage you not to attend. And we'd pay, if you had paid us something, we'd pay you that back. We'd give you a full refund. You have to be encouraged not to attend if you're not feeling well. Yeah. Another thing we're very proud of, we were the first country in the world to be able to have, sporting events, with full stadia of people, 30, 40,000 people in a stadium, which, that is indicative of the strength of what we've done in New Zealand, in fighting COVID.
I think you better stop saying what's so great, because the world is already envious of New Zealand and your Prime Minister and everything that you had. But going back to health IT for just a little bit, we talked a bit about the infrastructure that is basically only starting to get developed. So one thing that I wonder is, what do the efforts for the infrastructure mean in terms of standards? One of the goals is to enable innovation by breaking down silos and supporting new types of data use. And according to the Ministry of Health, New Zealand is data rich, but just the connectivity is missing.
Increased in importance over the, let's say, last 10 years. And we've got a very good health standards organization. It's called the Health Information Standards Organization, or HISO, HISO for short. And that's a committee within the Ministry of Health. And it's got various representation, people on it that represent parts of the sector. And we have what's called an industry representative. So one of our members is around that HISO table, so to speak, in that committee, and that's happened. He joined them about 2 years ago, so we have got an increasingly stronger or strengthening focus on standards, and it's generally, I find, on the industry side, which I tend to represent more of. There's a very high awareness of the need for standards and the adoption and use of standards, particularly in the area of, for obvious reasons, security and privacy, interoperability, and we're introducing SNOMED, which standards have been a SNOMED country for quite some time, but now it's sort of becoming more and more important. Our standards are not mandatory in the health system, apart from those that may be linked. We've just had on the 1st of December, we have a new Privacy Act or legislation or law is being introduced to replace the previous Privacy Act, and that has some mandatory aspects to it if you are collecting any records, any personal records, but then some additional requirements if those records are health related and personal health related. So, but the majority of our standards are encouraged rather than mandated, and that's caused some issues in the past. If as a healthcare provider or a IT provider, if you chose not to follow a standard or adopt a certain standard, you might say, "Oh, well, I'm using a standard from overseas, which is better than this standard, then I'll use that one and not this one." So that's caused a bit of inconsistency, but I'd say in the last, 3 to 4 years, I've seen much greater improvement in that area, and it's going to just continue to improve. Particularly I mentioned the health information platform. There's quite a strong emphasis on standards adoption and sort of consistency of standard adoption, not necessarily mandating, but again, I think it's going to reflect through into the contracting. So if you get a contract, say from a DHB, for example, for a system, you'll find with more and more now that contract will require certain standards to be implemented and met.
What are you hopeful about in the next 3 to 5 years in terms of healthcare IT development? And perhaps even your professional path, you are going in a different role now. Maybe you can say a word or two about that as well.
Yeah, from an IT perspective, so drawing on what I've been doing for the last few years, in the next, say in 5 years' time, what I'd like to see is, we should have by then achieved full interoperability across the health system. So we should have an environment or an ecosystem that's where we see data flowing, data and information. So if I talk about me, so my record or my data, my information about my health care should be able to flow to wherever and whenever that it's needed to provide care for me. And that's clearly it's got to be done in a safe and secure and private manner, but it should be happening. So, if I, at the moment, for example, particularly in the North Island of New Zealand, if, I live in Auckland, but let's say I was down in our capital called Wellington and I injured myself, I might fall over and break my leg, and I get taken to the local hospital there, that local hospital in Wellington won't be able to look up my record in Auckland. And so they will be asking me questions like, well, am I allergic to anything? Am I on any sort of medication? And so they rely on me to remember that or know it. Mm-hmm. And, if I'm knocked out, I might be unconscious. Well, how can I answer? So the South Island, that region they've adopted a system called Health One, which does tend to join up the data better at the moment. So, interoperability should allow me as a patient, as a person requiring care at any given time, not only to be able to access my own record no matter where it is. I should be able to see what my health record says about me, and I should be able to update it where there are things that I need to update. It might be simple things like my phone number or my next of kin or whatever. I should also be able to see who else has been looking at my health record and doing something with it. So there needs to be an audit trail there. And then I should also be able to determine who gets to see and use my record and who doesn't. So my GP should be able to have full access across wherever my health record sits, and because some of it might be in a hospital, some of it might be in the general practice, some of it might be at my physiotherapist or let's say chiropractor if I go to one, those sorts of things. So I'd want my GP to look at all of my record, but my physiotherapist may not need to see my record about my last visit at the hospital, unless it's related to something that they're working on. So I think that's really important. And I think until we achieve that, it makes it very hard for people to take responsibility for their own care.
In that regard, you can learn a lot from Australia, which is close, and their implementation of My Health Record and many issues that they faced. I recently had a discussion about that.
Yeah, well, that's a dangerous thing because Australia and New Zealand enjoy a very special relationship built up over many years, but we have a very strong and a high rivalry amongst each other across the Tasman Sea, as we call it, or across the ditch. So we would say that actually we think the Australians might be telling a few little white lies there about how well it's working for them, and so.
Yeah, it's so the discussion that I had was actually not that great, in a sense that the My Health Records project seems to be in the catch-22 situation, where because not all hospitals are digitized, not all patient data gets in the record, which then means that doctors don't really see the meaning of putting information in the record if it's incomplete, and at the same time they can't rely on that record of a patient if they're not sure if everything is inside. So it's kind of like, how will you drive adoption when the whole system is not digitalized yet? So you still have the opportunity to do better.
I can assure you, we will do better. We're driven to. We beat them at rugby. We beat them at most sports, and so why can't we beat them at this? I'm actually. If there's any Australians that are going to be listening to this episode, I'm purposely stirring them up as well, of course, so, which they would do to me as well. We have a very collegial relationship, but at times, we do tend to. Yeah, we take that rivalry pretty seriously. But on the other hand, when it comes to economically and other areas, we're very, very good friends. So the other question you asked, I think one of the things that I'd like to see, let's say one of the things that I've heard and I've observed for many years now and still do, is clinicians and non-clinical healthcare workers at the coalface struggling every day with just what I would call just sort of common, fairly easily fixed issues that are related to IT. So where, for example, just the lack of mobility, or the having a device where you can just access what you need to know about that patient or that person you're caring for, or their family, for example, who may be querying some problem, and it's so difficult at times to be able to give people information that will help them. And that includes the clinical and non-clinical workforce. I would like to see a point where their frustrations, you no longer hear their frustrations, really, where they go, and some of it can be where a GP or a clinician in a hospital, or even a healthcare worker going into a person's home to care for them, is some of their job, a big portion of their job now, is just entering data about that patient. Mm-hmm. They've become sort of data entry people as opposed to being clinicians or carers. So IT, has got some magic there which can solve so many problems, but we seem to also create additional problems which don't seem to take their workforce into account, and ultimately the people that they care for. And one of the things harking back to my background in healthcare and healthcare delivery, and where I'm going back to with my new role, I always talk about that when somebody needs care at any time of their life, no matter whether they're a baby through to an elderly person, when people are not well and they need care, they're at the most vulnerable time of their life at that particular point in time. And so the healthcare system and the people delivering the care, have to be very cognizant of that, so that you're dealing with vulnerability. It may well be just a sore toe, or it might be it might be COVID. Doesn't matter. A sore toe creates its own level of vulnerability. You become vulnerable when you're relying on someone else to look after you, whoever that someone else might be. And that person that's doing the caring or providing the care has got to have every possible tool possible at their disposal to do the best that they possibly can for that vulnerable person. And I don't think IT is doing that very well at the moment. I think it's solving some problems, then creating new ones. And so in 5 years' time, I'd like to see, what good would look like would be that the providers of care, those people at the coalface, are not complaining about the problems that IT are creating for them. It becomes ubiquitous. And we don't actually talk about IT or health IT or digital health anymore. It's just healthcare. It's because it's part of it. And it will achieve that when it solves the problems and doesn't create new ones.
You've been listening to Faces of Digital Health. If you enjoyed the show, leave a rating or a review by going to www.lovethepodcast.com/Faces of Digital Health, and you will be redirected to the platform appropriate for your device. Stay tuned!